Very interesting session, the first one. It really focused on the theme of this conference, which is quality improvement and patient safety. Just to go along with the same theme, in this session, we'll be talking about what really shaped quality improvement in the past few years. We're going to talk about researches that really are considered landmark trials that shaped quality improvement. And I am happy to introduce our moderators for the next session. First of all, we have Dr. Sultan Yahya Asiri. He's a neonatologist in Khamis Mshet Maternity Children's Hospital. He's in the Asir Health Cluster. Did the training back in 2018, and he's a consultant neonatologist there. Now, next we have Dr. Noura Salim. She's assistant professor of pediatrics at Princess Noura bin Abdulrahman University. She currently leads the NICU division at King Abdullah bin Abdulaziz University Hospital and the NRP program at Princess Noura Simulation Center. So for this session, we have Dr. Umar presenting, and then we'll have the abstract competition with all of our referees that we have, okay? So without further ado, please take over.
Thank you, Dr. Talal. Assalamu alaikum, sabah al-khair. Thank you for invitation to be part of this great conference. Our first speaker in this session will be Dr. Umar al-Khatib. Dr. Umar al-Khatib is a board-certified neonatologist who completed his pediatric training in Jordan and Canada. He pursued a neonatal perinatal medicine fellowship at the University of Manitoba, followed by targeted neonatal echocardiography training at the University of Toronto. He has served as a consultant neonatologist at Sick Kids Hospital, Toronto, and since 2015 at King Fahd Medical City in Riyadh. Dr. Al-Khatib is an examiner for the Saudi Council for Health Specialists, chairs the Neonatal Policies Committee at King Fahd Medical City, and has special interest in neonatal hemodynamics, HIE, PDA, and functional echocardiography. Dr. Umar, you have the floor.
Jazakallah khair, Dr. Sultan. It's a pleasure to be here. Thanks for the steering committee for inviting me. My talk, inshallah, in the next 20 minutes will be about landmark neonatal studies in the last 5 years. I have no competing interests to declare. The objectives is to review key neonatal RCTs between 2020 and 2025, emphasize the importance of evidence curation and dissemination. كلمة curation معناها انتقاء. زي ما if you are choosing fruit from the tree, you choose the best fruit. So curation, انتقاء. Dissemination means نشر. And then highlight the role of EB-NEO in translating research into bedside impact. And EB-NEO stands for evidence-based neonatology. As we know, that neonatal research output is massive, but not all studies change practice. Only a few trials have sufficient design rigor, relevance, and reproducibility. So to identify the signal within this noise is essential for safe evidence-based care. This is an approximate number of neonatal studies on PubMed per year. As you can see, in 2025, approximately 18,000 studies have mentioned the term neonate or infant or premature or NICU in them. It's a huge number. Who can cope with such a big number? I don't think anybody can cope with this number. So that's why there is EB-NEO, evidence-based neonatology. It's founded to curate and interpret neonatal evidence. It's a global volunteer network, so it's completely non-for-profit. There is no profit, and there is no payments in it. It's just you are volunteering. The mission of eBNEO is to bridge research and clinical practice through concise, critical summaries, and the output of eBNEO is the impact article of the month. Every month since 2018, there is an impact article of the month in neonatology, and then among those impact article of the month, an impact article of the year is chosen every year, and that's present on the website. Haidar, if you can open the Microsoft Edge, please. Haidar. Just show you how to find the impact article of the month and how to find the impact article of the year in neonatology using any internet browser. So we have two websites open here, ebneo.org/vote. Try to record this website on your phone. Scroll down. So September 2025, August 25, so on, so on. Every single month. Scroll to the bottom of the page, please. And so on. And then open the other tab, which is Article of the Year. Scroll down. Again, so Article of the Year of the 2024, Article of the Year for 2023, 2022, 2021, and so on. Back to the presentation. So this is a website that chooses the best article in every single month in neonatology and posts it here and gets voting to decide what practitioners actually think is the best article. So there is a systematic monthly screening of more than 100 journals. It's graded by study design, sample size, and potential practice impact. There is editorial voting and independent peer discussion. And there is transparent posting with plain language summaries on social media like X or Facebook or Instagram or LinkedIn. eBNEO has accounts on all of them and posts. If you are a follower, you're gonna see those summaries. Okay, so what is a landmark study? A landmark study is a robust, reproducible evidence that changes practice or understanding. Think the TIP trial or the CAP trial or Felix et al. About hypothermia in preterm infants, or the TOBI trial. You know, those big RCTs that actually had impact on evidence. Those are landmark studies. There is a lot of fake and weak research, and so this is a lot of noise. And the task of eBNEO is to take this noise away and make you focus on the signal, which are good articles. So, as you are aware, there are lots of data in the literature. You need to do curation, so choose the best article. Oops, sorry. Curation, and then dissemination, implementation, and then you'll have impact. So eBNEO makes this practice much easier and much shorter for you. There is no profit for it. There is no money this organization is taking for. It's just volunteer work. This is the social media team, which was selected a couple of years ago. I did not submit my photo, so they just put the eBNEO logo under my name. And as you can see, those are neonatologists from America, Australia, Canada, Europe, Saudi Arabia, and many other countries. Japan also. This is the mission and vision of eBNEO. I'm not going to waste time here. There is eBNEO's team led by Dr. Ravi Patel, professor of pediatrics in Emory University. Also on the EBNEU board is Harish Kirpalani and Barbara Schmidt. They are board members. This is a photo of us a few years ago when we met in the PS meeting. This our number of Twitter followings or X followers. And this is an example of the journals we scan. So all the top-tier journals in the world, plus many other less famous journals. So we do a lot of work before we post and after we post about any article. And then we choose 3 or 4 articles published within the month for a public vote to choose the impact article of the month among them, ebneu.org/vote. And then among the impact article of the month winners every year, we choose the impact article of the year, again, ebneu.org/impact. Are there other neonatal blogs? Yes, Michael Narvi and Keith Barrington. Each of them has a famous neonatal blog, but they are doing things a little bit different than what EBNEU is doing. They have great discussion platforms. They are very good, but their job is not to publish every good article within the field of neonatology. Okay, so enough with this introduction, I guess. Now, I have collected 25 articles. I'm not gonna go in depth in all of them, just to show you the kind of evidence that has been curated over the last 5 years within the field of neonatology. This is just an example. I don't want you to go out from this lecture and say, I know this evidence. No, this is not my job. My job is to show you how to find the evidence, how to find the evidence, and how to discuss this evidence, how to vote for an article to be the impact article of the month or of the year. So starting with the top trial by Harish Kirpalani, published in New England Journal of Medicine, higher or lower hemoglobin transfusion thresholds for preterm infants. They used, in the first week of life, 13 versus 11, in the second week, 12 versus 10, in the third week and beyond, 11 versus 8.5. And in their results, they showed that the higher hemoglobin threshold for red cell transfusion did not improve the survival without neurodevelopmental impairment at 22 to 26 months of age. This is a high impact study that will affect the decision to transfuse an infant in the NICU, which is a very common practice. And most of us will ask, what's the threshold? When should I transfuse? This is a study that answers this. The second example, initial laparotomy versus peritoneal drainage in extremely low birth weight infants with surgical neck or isolated intestinal perforation, multicenter RCT by Martin Blakely. In this study, they compared the efficiency of laparotomy versus Penrose drain. Again, this is a very common practice in the NICU. And they showed that the posterior probability that laparotomy was beneficial was 97% if the diagnosis is neck. So if you have neck and you have free air under the diaphragm, they are saying it's better to do laparotomy than inserting a Penrose drain. But if the diagnosis preoperatively is likely to be just perforation like SIP, then the probability of benefit with laparotomy is low. It's only 18%. The third study is the immediate KMC or kangaroo mother care, and this is published in the New England Journal of Medicine by the WHO group. And they showed that neonatal death mortality has been reduced in these countries where this study was done, which is Malawi, Bangladesh, and India. They found that mortality has been reduced with the KMC. This article has been actually voted the article of the year of 2021. RCT of fetal surgery for moderate left diaphragmatic hernia. As we know, there are many studies before this study that has asked the question, is doing surgery, fetal surgery, for a fetus who was diagnosed with CDH, is it useful or not? This study gives a final answer. And the answer is, it's actually not superior. So not every good study has to be positive, showing, yes, this is a good intervention and you should do this and that. No. If a study answers a question saying that it's not actually useful, then it is a good study because we didn't know this before. There is always a debate whether when should we do fetal surgery. طبعا, we are talking about advanced centers. So this study just puts an end to this debate, saying it's not superior. Fetal surgery is not superior. It actually has more complications with preterm delivery, NICU admissions, and so on. And when we talk about landmark studies, we should talk about Hammett et al., the Melody study, Nirsevimab for prevention of RSV in healthy late preterm and term infants. As we know, the standard for RSV prevention is Synagis or Palavizumab. Now there is a new monoclonal antibody called Nirsevimab, or Beyfortus. I think the trade name is Beyfortus. And by the way, same company. This is not a competing drug. The same company that made Palavizumab is the same company that made the Nirsevimab. So they studied it on a very big group of infants for the prevention of RSV disease. The first study was in late preterm and term infants, اللي هم 35 أسبوع لحد الترم. And the second study in all preterm infants بدءا من 29 أسبوع وطالع. So two big RCTs, and both of them published in New England Journal of Medicine. And Nirsevimab has been found to be effective and actually cheaper than Palavizumab. Very good efficacy. Very severe RSV-associated disease occurred in 0.1% in the Nirsevimab group and in 0.5% in the standard care group. Those are thousands of infants. So 4,000 in each arm, so 8,000 infants, a huge RCT. The second, طبعا, we cannot talk about Nirsevimab without mentioning the new vaccine for RSV that's given to the pregnant women to prevent RSV in their offspring. And it has been also published in the New England Journal of Medicine and is been found to be effective in preventing RSV disease. So again, I'm not here to show you the studies. I'm here to show you how to find those studies. Just log into ebneo.org. You don't need even to make an account. You don't need to make an account. Even just follow them on Facebook or X, ebneo. This is the name. Nasal high flow therapy during neonatal intubation by Hodgson et al. This is done in Australia. It's found to be actually very successful in reducing the intubation failure. This is a practice change study because by routine, we are intubating children while they are on room air or just like nearby oxygen. They have shown that giving high flow during the intubation has made the intubation more successful, has decreased complications, and is safe. Again, another New England Journal of Medicine. طبعا NEJM is #1 journal in the world. So if you see a neonatal study published in NEJM, then it's a good study, probably. Not that it's no mistakes in it, but it's a robust evidence. It's something that has a lot of hard work on it. Expectant management or early ibuprofen for patent ductus arteriosus by Hanschild, which showed that expectant management is actually not inferior to ibuprofen, and in many cases actually safer, where ibuprofen can cause renal impairment or necrotizing enterocolitis or SIP, or bleeding tendency and so on. They have shown in this study, where they recruited 273 infants, that expectant management, which is basically restriction of the TFI, increasing the PEEP, allowing permissive hypercapnia, and just conservative management versus a medical treatment. They showed that ibuprofen is not superior, okay? Trial of erythropoietin for HIE. Erythropoietin, I know some of my colleagues here have used erythropoietin for babies with HIE because there are studies on it. But this study has answered this question, saying that actually erythropoietin is not effective. So you better not use this medication because it does not improve the outcome. Very good study where they studied 500 infants. 500 infants, big RCT for EPO in HIE. The next one is about antenatal dexamethasone for late preterm infants, multicenter, double-blinded, placebo-controlled randomized trial in Lancet. And they showed, again, steroids for this group are not useful. They should not be used routinely. Again, this is one of the debatable spaces. If you give DEXA for a mom who is in labor at 35 weeks, does it improve outcomes? The study says no, it does not. And actually causes more hypoglycemia and causes problems in some babies. So it shouldn't be a routine use. RCT of surfactant therapy via LMA. And we know the new NRP is coming this year, inshallah, where LMA will be more utilized for resuscitation and also for surfactant administration. This study have found that using LMA is actually safe for surfactant administration. It's a big RCT, studied 51 versus 42 infants, and the efficacy of LMA was high, safety was acceptable, and then something to consider. If you are not able to intubate, if you are in a level 2 where the intubation skills are not so good, can I use LMA for administering surfactant? Yes, you can. Anoop Kasaria, the king of cord milking and delayed cord clamping in the world, he's a neonatologist who works in California, published about umbilical cord milking versus delayed cord clamping in infants between 28 and 32 weeks. What do you think is the outcome of this study? Can anybody tell? No? The same. So milking is an acceptable alternative for delayed cord clamping in this particular gestational age group. Why? Because remember, this is a baby who has RDS that needs resuscitation. So nobody wants to wait with 30 to 60 seconds of delayed clamping. They want to bring the baby immediately to the resuscitator and start resuscitation, right? So he has found in this RCT that milking is an acceptable alternative to delayed clamping in this age group اللي هي 28 ل 32 أسبوع.
5 minutes دكتور عمر.
5 minutes قبل كده إن شاء الله. The next one is about higher versus lower nasal CPAP. It's called the ECLAT study. Again, multi-center randomized superiority trial by Kidman et al. an Australian group. And by the way, Australia is #1 in the world in the studies of high flow and nasal CPAP. Nobody is better than Australia in the CPAP studies. And they compared two groups of infants after extubation. So an extreme preterm baby that is extubated between 5 and 7 CPAP, and then the other group between 8 and 10. They have found in this study that the higher CPAP group, اللي هي من 8 ل 10, have actually done better than the other study. Unfortunately, many of us have what I call peebophobia. We are just concerned about high PEEP because pneumothorax and so on. The study is showing it is actually safe to extubate a baby to a CPAP of 10. And that will decrease the extubation failure, improve the outcomes, and so on. This study has been voted Article of the Year of 2022, I think. This is a follow-up of the Planet 2 trial. Is anybody aware of the Planet 2? So Planet 2, a big RCT from 2019 that compared higher versus lower thresholds for platelet transfusion. ايش الهاير 50,000 ايش اللور 25,000 to transfuse platelets if the platelet count is below this number. They have found in the early phase اللي هي Planet 2 that the lower threshold 25,000 they did better actually than the يعني if you transfuse only if the platelet count أقل من 25,000 in a preterm baby, the outcomes are better than if you transfuse if the threshold is 50,000. Now this is a follow-up at 2 years of age, and surprisingly, surprisingly, even at 2 years of age, the group of the 25,000 did better, had lower NDI, اللي هو neurodevelopmental impairment, had lower mortality. So that answered the question, what is the threshold I should transfuse babies on, platelet count? 25,000 is better than 50,000 and safer. Early human milk fortification in infants born extremely preterm, RCT. I'm not gonna highlight this study a lot, but it's safe to fortify milk when, like, even on protocol feeds. You don't need to be on full feeds to be fortified. Effect of early versus late inguinal hernia repair on serious adverse event rates in preterm infants. This is a very common question in the NICU. You have a baby born at 27 weeks, approaching discharge. Upon examination, you find an inguinal hernia. When should I operate this baby? Very common question, right? The study answers it. Actually, it's better to wait. It's okay to accept the inguinal hernia and not to rush for surgery before discharge. You can come back later for discharge. And the outcomes were very good because everybody thinks, no, it's hernia, it will strangulate, it will obstruct, and so on. It doesn't. Preterm pathophysiology is just different. So this study has answered this question. STAT trial, again, this is another surgical study, stoma versus anastomosis in the diagnosis of neck. So a baby who is undergoing laparotomy because of neck. If the surgeon sees necrotic segment, is it better to do ileostomy or is it better to just resect and reanastomose and close the laparotomy? We did not know the answer for this until this study. The answer is resection reanastomosis is better. Last study I will show is Fairchild, and Fairchild has been voted the article of the year of 2024. Fairchild is a neonatologist in Washington, and the study was about ventilator assistance before umbilical cord clamping in extreme preterm babies. And the study did not show that providing assisted ventilation before clamping reduces IVH or death. So again, this has been asked before. If I'm doing delayed cord clamping, should I provide bagging PBV during the clamping, or should I just wait? The study is showing that this bagging on PBV during the clamping is not useful. Again, it just ends the debate. 570 infants, big study, big RCT.
Dr. Umar, can you?
خلاص. Yeah. Just a minute. طبعا فيليكس إيتال whole body hypothermia in preterm babies. This study اللي هي اللي فاتت هذه has actually changed the Saudi national protocol من 35 أسبوع إلى 36 أسبوع. See, this study had an impact. Thank you. This is ebneo.org.
Thank you, Dr. Umar, and sorry for this. But we will have only 2 questions for sake of time before we move to the next event.
Stimulate people to ask, not to say. شكرا دكتور عمر. We really enjoyed. دائما ممتعنا ما شاء الله عليك. لكن a question always will comes when we have contradicting results in these trials. You show us a lot of things that is conclusion, but sometimes you may have another studies or trial which shows conflicting result than this. So what will be the evidence better? We go to Cochrane will tell you we need further study to confirm it. So not a senior, as a junior neonatologist, I get confused when we have 2-3 trial contradicting results in each other. Thank you.
Thank you, Dr. Abdurrahman.
I'm still junior.
So that's when the critical appraisal is needed. So critical appraisal بالعربي التقييم النقدي لأي دراسة جديدة. We need to do it in details, right? Not just say this is NEJM publication or this is JAMA publication and آمنت بالله وخلاص وراح أنفذها عمياني. لا, you need to critically appraise. You need to make sure that the study population is similar to your population. The study resources is similar to your resources. لأنه sometimes خاصة في موضوع PDA مثلا. Okay, PDA has not been found to يعني treatment of PDA has not been found to be useful. However, we have higher than average rate of pulmonary hemorrhage because many hospitals suffer from decreased quality of nursing care, like maintaining the CPAP mask on face. Can I apply results تبعت البنديكتس trial أو تبعت ibuprofen expectant management? Can I apply it 100% here? No, I can't, because the quality of nursing care is different. If I am having more than average rate of pulmonary hemorrhage, probably I need to close more PDAs to prevent this pulmonary hemorrhage. Okay, so the applicability part is very important. It's not just I have the evidence, you shouldn't do this or that. You need to make sure that the applicability of the study in your own setting, critically appraised. And among the studies I have shown here, I'm not aware of any big RCTs that's actually contradicting them. There are smaller prospective observation studies that are maybe contradicting, but like large RCTs, like for the nirsevimab, there is no study that says nirsevimab is not effective. No study. Okay? And inguinal hernia, there is no big RCT. This is the only big RCT about inguinal hernia repair, and so on. Yeah. Yes, exactly. Think globally, act locally.
شكرا دكتور عمر. I think it's a comment and it's a question for everyone here, especially the leaders. When are we going to be on the map as Saudi neonatal network? We're not on the map. We're still presenting others. We're on the map, football-wise or soccer-wise. Well, everyone knows that we have such and such, but no one knows our population. No one. When are we gonna have our multi-center collaboration? When are we gonna publish our own? دكتور عبد الحكيم قال احنا عندنا low rate of BBD. من زمان احنا عندنا low rate of BBD, but nobody knows. We're not collaborating to publish. I'm saying that now. I always have these thoughts, but I never was encouraged to say that. But I'm saying that now to inform everyone, and I inform Dr. Jubara. In the university, inshallah, we're working on a database that is going to be international for international people to see. But as a center, it will never be on the map. We need to be multi-center. And it's only the Saudi Neonatal Society we can say that. Where can we say that? So it's for everyone to think about. We're happy to collaborate.
الله يجزيك الخير يا دكتورة هايدي.
Thank you. Now I will give the mic to Dr. Anora for the next event.
يعطيك العافية دكتور. السلام عليكم everybody. We'll move to the second session for second part of our session today. It's nice to be here between the most expert and our young future neonatologist. So in this session, we'll be presenting the abstract competition. First, I would like to invite our judges, starting with Prof. Saleh Al-Alayan. Everybody knows Prof. Saleh. He's one of the key founders of the Saudi Neonatal Society and a well-known figure in new research, and participated in a lot of research in the kingdom and in developing guidelines in Saudi Arabia. The second judge is Prof. Khalid Al-Faleh, professor at King Saud University, currently in Suleiman Habib Group, well-known researcher and in Saudi Arabia with multiple publications. And our third judge, Dr. Mohammed Al-Hindi, head of section of intensive care unit, National Guard in Jeddah. So kindly judges, you're welcome to join us in the podium. So we'll start our first abstract presentation. We have 5 abstracts today. So the first, actually each abstract will have a presentation 5 minutes, followed with 2 minutes of questions by the judges if they have any question for the presenters. So we'll start with the presentation of Dr. Abdullah Safar Al-Ghamdi. His presentation abstract will be about impact of free feeding syndrome on the short-term clinical outcomes of very premature infant. تفضل دكتور, you have 5 minutes to present your abstract.
Good morning. First, I would like to thank the Saudi Neonatal Society to give me this opportunity to present this case. It was done at King Saud Medical City during my fellowship. So today, inshallah, we'll talk about impact of free feeding syndrome and short-term clinical outcome of premature infant. Refeeding syndrome, it was electrolyte disturbance, lead to fluid shifting when the nutrition rapidly starting after prolonged MBO. It's triggered by insulin surge, lead to electrolyte move intracellularly, and lead to hypophosphatemia and hypokalemia. That can lead to complications like cardiac, respiratory, hematology, and neurological complications. As we know, the preterm infant lack the third trimester nutrition creation lead to low reserve at birth, small gestational age, and IUGR further hitting deficiency risk. As we know, the recommendation for protein intake, it was 3.5 to 4.5 grams per kg per day, but excess of that can be lead to acidosis, hyperammonemia, and precipitate breastfeeding syndrome. Refeeding syndrome rate in the very term infant very widely reported at 20% in profile trial and up to 90% at high risk for small gestational age, IUGR, or early aggressive parenteral nutrition. The variation likely reflect different definition and population, but the remaining syndrome common and clinically important problem worldwide. There is no clear definition for the refeeding syndrome yet established, but after review, the literature review, we use that definition: hypercalcemia more than 2.8 millimole per liter, hypophosphatemia between 1.1 to 1.6, and severe hypophosphatemia less than 1 millimole per liter. So our aim of a study to examine the short-term clinical outcome of refeeding syndrome in the preterm infant less than or equal 32 weeks of gestational. And it was a retrospective review study done at King Saud Medical City at NICU level 3. The data collected from January 2015 to June 2024 with annual admission in our in the King Saud Medical City is 1,100 per year. It was approved by ethical committees and informed consent waived. So we include the preterm less than 32 weeks with the weight less than or equal 1.5 kilogram, born at King Saud Medical City, and starting TBN, parental nutrition plus lipid within 24 hours. We exclude congenital malformation. Patient did not receive parental nutrition, outborn or transferred to another hospital, either missing data or died within 7 days of life. So the primary outcome study was short-term clinical outcome for refeeding syndrome preterm infant born at less than 32 weeks of gestational as IVH mortality or long duration of TBN. So regarding statistical analysis, infant maternal data summarized as median frequency, t-test for normal data, Mann-Whitney for non-normal, Fisher for categorical. Also, we use the univariate relative risk to use link refeeding syndrome with neonatal outcome, and the p-value less than 0.05 was considered significant. So we include 2,465 preterm. It was initial not meet inclusion criteria. We exclude 1,705 due to our excluding criteria. The remaining 760, and the baby we have refeeding syndrome is 289, and without refeeding syndrome 471. So in this diagram, we found that the refeeding syndrome patient has low gestational age, low birth weight, and low Apgar score with statistical significant with the p-value. And moreover, the male sex, it was high risk for the refeeding syndrome than the female. Also, refeeding syndromes found developed for patients that require more surfactant, more dose of surfactant, and average the peritoneal lipid, protein, and phosphorus, and total duration, it was associated also with refeeding syndrome. In this univariate analysis, we found significant associated refeeding syndrome with neonatal morbidity and mortality. So we found statistical significant for composite outcome, mortality, IVH, severe IVH, late onset sepsis, and bronchopulmonary dysplasia with statistical significance less than 0.001 respectively. And also there is no association between duration of invasive ventilation and length of stay in the hospital. Here in multivariate regression analysis, we find significant associated refeeding syndrome with composite outcome IVH and IVH with adjusted relative risk factor 1.7, 1.59 respectively. Moreover, the hazard ratio for death infant with refeeding syndrome increased by 1.74-fold. So in our discussion here is a patient less than 32 weeks developed refeeding syndrome in the first week, has associated with high IVH, hospital mortality, BBD, and late onset sepsis. No significant difference were found for duration of mechanical ventilation between refeeding syndrome and non-refeeding syndrome group. The key risk factor, it was male sex, IVH, and low sodium phosphate intake in first week. And other reports, they found the IUGR and the small gestational age and high amino acid strategies. Consists with profiled study, the refeeding syndrome triple mortality and severe hypophosphatemia, 5-fold higher IVH risk. And in our cohort, the mortality rate was 42% for refeeding syndrome patients compared to 32 in the profile. And there is no significant difference between non-refeeding syndrome mortality between two studies. And also the refeeding syndrome with IVH is high link is echoed by another different studies. Some study found there is no difference for mortality and IVH due to small sampling, low IVH incidence, or variable refeeding syndrome deficiency definition. And late onset sepsis, most study, including the profile, show no difference, but there is another study like Malto, they found the higher late onset sepsis with very low birth weight. So in conclusion, preterm infant less than or equal 32 weeks. The patient developed refeeding syndrome within first week of life. It was high risk of IVH, mortality, and long duration of TBN. And our recommendation to be standardized neonatal refeeding syndrome definition across in ICU, multi-center prospective trial to optimize parental nutrition balance, and implement structured lab monitoring via multidisciplinary team. Thank you.
Thank you, Dr. Yatik Al-Afia. Any questions from the judges or the audience?
Nicely done, nicely done. Allah, mashallah, Allah يبارك لكم. بس what did you, because you had a table of regression, so what did you adjust for? يعني عشان refeeding, as you said, it's not easy to define. So what did you adjust for? That's the first question. Number two, as you mentioned, hypophosphatemia is a big thing in this refeeding thing. So where is phosphate here? Like the intake, the levels, the difference between the two groups, where is it there? Thank you. If you want me to repeat, I can repeat.
Yeah, please.
Repeat?
Yeah.
طيب. First, in your regression table, you said adjusted odds or risk. So what did you adjust for?
So we adjust that, we try to apply that IVH bundle for that patient, and also monitoring the TBN with the lab to avoid this complication.
I don't think you got my question. We can discuss it after. The other question was phosphate monitoring, or in terms of intake or levels, part of this study?
Yeah, it was monitoring by the lab monitoring.
Sure, but was there a difference between the two groups?
Yeah, that patient has low, because this study came from the previous study, the incidence of the refeeding syndrome in our center.
So what I mean was the hypophosphatemia more in the refeeding syndrome?
Yeah, it was more in that patient with refeeding syndrome.
Yeah, because many relate what's happening to the hypophosphatemia per se and the amount of protein. I saw that you mentioned the amount of protein, but well done, thank you.
Thank you very much, Doctora. Thank you very much, Dr. Abdullah. We'll move on to the next presenter. Dr. Mohammed Ahmed Amr Salaut will present a ROX index as an indicator of non-invasive ventilation failure in neonates. تفضل دكتور.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the organizing committee for giving me this chance to present my research in King Faisal Specialist Hospital and Research Center. My research is about ROX index as indicator of non-invasive ventilation failure in units. A predominant reason for admission to NICU is respiratory distress that may need respiratory support ranging from non-invasive ventilation to invasive ventilation. A significant cohort of patients may experience deteriorating respiratory function despite initial NIV support. To predict NIV failure, medical professionals rely on a blend of clinical judgment, ventilator setting, blood gas analysis, and vital sign monitoring. No widely adopted objective tool tailored to neonates to anticipate non-invasive support failure. ROX index is defined as the ratio between SpA2 divided by FI2 to respiratory rate. The ROX index has been used as potential predictor of NIV outcomes in adult and pediatric cohorts. There is no published data in neonatal population until present. Our objective of the study was to evaluate the diagnostic accuracy of the ROX index measured at 72 hours of age after initiation of CPAP or high flow nasal cannula or post-extubation to non-invasive support for predicting weaning success and to identify clinical factors associated with weaning failure. For the method of the study, it was a retrospective cohort study that includes all neonates admitted to NICU at King Faisal Specialist Hospital and Research Center in Riyadh from January 21 to end of December 22. Data were collected from the Medical Record Integrated Information System, short ISIS, and NICU database. The ROX index was collected from the ISIS or calculated manually from the displayed vital signs and the FiO2. We included all neonates who required NIV as initial mode of respiratory support in the first 72 hours, or all neonates were initially intubated, then extubated to NIV within the first 72 hours of life. We excluded all neonates with major congenital anomaly, major brain insult, major airway malformation, or patients who required elective intubation for short-term procedure. Primary outcome of our study was treatment failure within 72 hours after starting NIV. The treatment failure defined as when the baby reached receiving maximal support NIV, if high flow nasal cannula of 5 liters, or CPAP 7 cm water, plus at least one of the following: sustained increase in the FiO2 more than 50% in 1 hour to reach the target saturation 91 to 95, or any patient required urgent intubation and mechanical ventilation, or any patient needs escalation to non-invasive high frequency, or any baby who failed weaning off NIV at 72 hours, 2 hours of age. For the statistical analysis, we analyzed the data using Stata version 18. Continuous variables were summarized as medians with interquartile ranges, and categorical data are as counts and percentages. Group comparison used Mann-Whitney U test and chi-square test. Diagnostic performance of the ROX index was assessed by ROC analysis. The optimal cutoff was determined by Uden's index. Multivariable regression analysis identified factors independently associated with weaning failure, with results reported as odds and 95% confidence interval. For our results, we included 210 patients. Out of them, 133 patients were male and 77 were female. The gestational age, the median was 34, and the interquartile range was 32 to 35. The birth weight was 2100 as median, and the interquartile range 1660 to 2580. Patient who required mechanical ventilation was 39, and the duration of mechanical ventilation median was 72 hours. And we used surfactant in 89 patients, and 3 patients have air leak syndrome at the end of the study, and 2 patients required home oxygen, and the median length of stay was 13 days from 6 to 24 as interquartile range. The maternal characteristics: 141 patients received antenatal steroid, 9 patients were GPS positive, 22 patients delivered by SVD, 188 patients delivered by cesarean section, and 127 patients were multiple pregnancy, and 83 were singleton. Outcome of our study: out of the 210 patients, 166 patients succeeded the weaning from the NIV in the first 72 hours. The ROX index for this success group, the median was 9.7, and the interquartile range was 8.2 to 11.7. And 44 patients, was 21% of the total number, failed the weaning from the NIV in the first 72 hours, with median ROX index of 4.7 and the interquartile range 3.6 to 6.2. The overall ROX was skewed to the success group, so the median was 8.9 with the interquartile range 6.8 to 11.
Have 1 minute.
Factor associated with weaning failure: I think I have 10 minutes. I asked Dr. Talal to give me 10 minutes.
Okay, carry on.
Sorry.
Carry on.
That's okay. So factor associated with weaning failure, we did the univariable and multivariable analysis. We included all the data, including the outcome in the multivariable analysis. Out of them, the patient who required mechanical ventilation and the overall ROX index were statistically significant with p-value less than 0.05. In adjusted models, prior mechanical ventilation remained independently associated with failure, with OR of 7.6, 95 confidence interval 1.4 to 38. Higher ROX index at 72 hours were independently associated with weaning success. OR per unit increased 0.35 with 95th confidence interval 0.2 to 0.5. This figure is showing the rock analysis for our study, for the rocks itself. So it demonstrates excellent discrimination with area under the curve 0.947. The diagnostic performance of the ROXY index, a threshold of 7.1 at 72 hours. This is by the Uden's analysis, yielded sensitivity 88 and specificity 91%, with positive likelihood ratio of 9.7, negative likelihood ratio of 0.1, positive predictive value 97.3, and negative predictive value of 66.7. These parameters indicate that neonates who has ROXY index more than 7.1 are substantially more likely to be successfully weaned from CPAP or high flow nasal cannula, while lower values signal increased risk of early failure.
30 seconds.
ROXY index was initially developed in adults and with hypoxic respiratory failure, and more recently in pediatric population. Our study will add value by providing neonatal specific evidence. The clinical utility of the ROXY index in this setting appears twofold. First, the high role of performance at 7.1. Second, because the negative predictive value was more modest, low ROXY values showed promptly assessment rather than escalation. Significance of the study, it will add value by providing neonatal specific evidence for ROXY index, pre-specified time 72 hours, objective and clinical relevant failure criteria, and comprehensive capture of covariates from the electronic records. Our records include both initial non-invasive support and post-extubation cases, which increase generalizability, limitation, single center, retrospective, potential co-founders, duration of the follow-up, and distribution skewed to the late preterm. To conclude our study, the ROXY index measured at 72 hours is a promising predictor of readiness to wean neonatal patients from CPAP or high flow nasal cannula. A cutoff of 7.1 provides a clinical actionable balance of sensitivity and specificity, and may help standardized decision making, reducing both premature weaning and unnecessary prolongation of support. Prospective validation across diverse NICU setting is warranted. And this is my references. Thank you.
Thank you very much, Doctor. It's 7 minutes for presentation, 3 minutes for discussion. We even expanded because of the canceled last presentation. That's okay. No problem. Allah yawafqik, inshallah. No problem. So
we have to be fair with everybody. Even if you requested before the meeting, we have to be fair with all the competitors to give them enough time for their presentation. We'll stop at this stage. We'll allow only one question from the audience, and then we'll move on to the next one.
any question? تفضل دكتور.
This is a question. This is a good question. Actually, in the limitation of the study, the follow-up should be prolonged. 72 hours, by definition, it was the failure of both patients who are extubated. They define the extubation failure that the babies who failed extubation within 72 hours. So they reintubate within 72 hours. But actually, it can be prolonged because there is babies with BBD can be extubated later, and then it needs more and more collection of data after that. Thank you so much.
Thank you, Dr. Mohammed. Thank you very much. We'll move into the next presenter, Dr. Abdelilah Al-Shehri. He will present his abstract about pathogen profiles and antimicrobial resistance patterns of neonatal sepsis in Gulf cooperation. A systemic review. تفضل دكتور عبدالله.
السلام عليكم حياكم الله جميعا. My name is Abdelilah bin Faiz Al-Shehri, a medical student from Imam College. First of all, I would like to thank for organizing committee and also for giving the chance to share our systemic review, which is titled Pathogen Profile and Antimicrobial Resistant Patterns of Neonatal Sepsis in the Gulf Cooperation Council, which is a systemic review. So neonatal sepsis is still a major cause of death among newborns. It affects thousands of infants every year, especially in developing countries. We divide it into two types: early onset, which is usually come from the mother. On the other hand, we have late onset, which mostly hospitalized acquire. Even though Gulf countries have advanced in ICU, we still we still don't have enough clear data about the common pathogen or how resistant they become to antibiotics. That's exactly why we do this study. This is our objective. So the methodology behind our research involves several key steps. In the beginning, it's followed by the BERISMA guideline 2020. The number of studies include around 54, representing 5,177 neonatal sepsis cases, which is a huge number. We defined neonate as less than or equivalent 28 days. Our research covered all 6 countries, which is Saudi Arabia, Qatar, Kuwait, Bahrain, Emirates, across 3 major databases, Web of Science, PubMed, also Scoop, between 1985 to 2025. So it's a long systemic review. We include studies that reported as confirmed neonatal sepsis with identified pathogen, employed only observational study, which is a cross-sectional study and retrospective, or even cohorts design. We exclude any case report or reviews or conference abstracts. Studies with laboratory confirmation were excluded without laboratory confirmation. Finally, we conduct descriptive synthesis. We couldn't make meta-analysis because we have high heterogeneity. So this BERISMA flow chart show how we selected the studies for our review, starting from 949 studies. Then we choose only 54, which is article includes. So moving to the results section, this is where things get interesting. Across these 6 Gulf countries, we analyzed data from, again, 5,177 neonatal sepsis for, as you can see in the figures, gram-positive bacteria made up almost half of all cases. Moving to gram-negative, which is a 44.8, and small portion, around 6.9, is a fungal infection. When we look more closely at individual pathogen, the leading ones were coagulase negative staphylococci, followed by Klebsiella, Staphylococcus aureus, then E. coli. Now let's take an overview about resistant they have become, starting with the dominant gram-positive isolated, which is a coagulase negative staphylococci. Showed very high resistance to several first-line antibiotics, especially ampicillin, oxycillin, and erythromycin. In contrast, coagulase negative staphylococci stayed highly sensitive to vancomycin. Now let's move to the gram-negative side. Focus on Klebsiella, which were the most frequent gram-negative pathogen across our data. Klebsiella show high resistance to several first-line antibiotics, including amoxicillin and cefotaxime. This show that may of the usual first treatment line in ICU may not work anymore against the bacteria. So moving to discussion and clinical implication. First, the changing trends. We noticed that coagulase negative staphylococci have new replaced group B streptococcus as the main gram-positive bacteria. On the other hand, Klebsiella has become the leading gram-negative. Second, antibiotics resistant. We found that high resistance to common first-line drugs like ampicillin and oxycillin. So the usual empiric treatment are not working as well as before.
1 minute.
Okay. So to conclude, neonatal sepsis is still a major challenge across the Gulf region or even worldwide. The main message is our empiric antibiotics protocols need to update and develop. In short, there is a medical progress, but at the same time, the bacteria is getting stronger with the time. So before I end, I want to thank my research group for great effort. That brings us to the end of the presentation. Thank you. If there are any questions.
Do you have a segregation analysis whether you did ever early onset versus late onset sepsis?
Sorry again?
Did you do any segregation between the early onset and the very late onset?
Okay, thank you for this interesting point. We made it as a limitation in our study. Also, there is another limitation which is we generalize the data for all 6 countries. So it will be, inshallah, in a future workshop. Any question?
Okay, thank you very much, Dr. Abdullah. We'll move on to our next speaker, Dr. Dalal Ashmawi. She will present her abstract about risk factors associated with loss of follow-up for newborns with failed hearing screening. Experience from the Saudi Tertiary Care Center. Dr. Dalal, تفضلي.
Okay, good morning, everybody. I'm Dalal Ashmawi, pediatric resident in Prince Sultan Military Medical City in Riyadh. I'm excited today to share our experience and risk factors associated with loss to follow-up for newborns who failed the hearing test at our center. Okay, congenital hearing loss is one of the most common problems in newborns. We all know that early detection can have a great impact on the outcome. It has an impact on the brain development, speech development, and language development. In Saudi, we have made great progress. A screening program that was started in 2016 now has coverage more than 90% of the hospitals. So in 90% of the hospitals, all newborns are screened for any hearing problems. At our hospitals, our nurses are well trained to do the hearing test using the automated auditory brainstem response device with high accuracy. Usually the test will be done when the baby is at the age of 24 hours of life. We try and follow the 1-3-6 international rule, which says to screen a baby at the age of 1 month, establish a diagnosis, if any, at the age of 3 months, and start treatment by the age of 6 months. But we found a problem that was weakening this program. Many families, they're not returning for the follow-up, so a proper diagnosis was not being established, nor a treatment or an intervention was started. Even if we have the resources, the treatment was not given to the baby. This actually does not only weaken the pathway, it disables it. There is no point of doing a screen if we're not able to give the proper treatment. So our research aimed to investigate into that. Why aren't parents attending the follow-up? What is the reason? Is it common that they're not attending, or it's a small percent? So our study aims was to assess how many infants were lost to follow-up, how many parents they're skipping the appointment. And if there is a good number of parents who are skipping the appointment, why they're skipping the appointment, and based on that, try and find a solution that are practical and simple to fix the problem. So what we did, we reviewed all infants that were born between July 2023 till June 2024. During that period, a number of 8,000 babies, more than 8,000 babies were born in our hospital. They were screened for a hearing test using the same device I mentioned. Out of these 8,000 babies, 366 failed the test. So those babies, the 366 babies who failed the hearing test, were supposedly planned for a later follow-up appointment. So we looked into how many out of these 366 babies attended the appointment. What we found that out of the 366 babies, the number of parents who attended the appointment was 62 only. That's less than 17%. So we had more than 300 parents that skipped their appointments even though their baby failed the screening hearing test. So what we did, our team called the 304 parents and asked them one by one what were the reasons that they skipped their appointment. What we found is that the number one reason that covered more than half of the cases was parental unawareness or misperception. Most of the parents knew about the negative results, but they did not know that a follow-up was needed. Other parents knew about the negative result, knew about the follow-up, but they did not get the message that it was a very important follow-up to attend. 17% said that they forgot or had other priorities. 15% has actual logistical barriers. We can consider these results as good news because if more than half of the problem is awareness or communication, that's something we can work on rather than an actual logistical issue that is relatively harder to tackle. At our center, the loss of follow-up was 83%. That's very high. And we found that babies that were from the postnatal ward were more likely to miss the appointment in comparison to babies that are from NICU. NICU parents were found to be more careful with the appointments and understood the importance of follow-up. But parents of healthy term babies were most likely to miss the follow-up. So the message here, what we learned, is that every parent needs proper counseling, not only parents of babies who had sick or premature baby. Every parent wants the best for their baby, and it is our job as healthcare providers to help them and guide them and support them in giving that care for their babies. We need to guide them to make sure that no child is left behind. So, being a parent is already hard of its own. Imagine having extra appointments that you have to attend. So we really need to simplify the system and help and make the system more supportive for these parents. What we can do, first, start with strengthening parental counseling before discharge. We, as healthcare providers, understand the follow-up understand the importance of follow-up, but we're not delivering that idea to the families. We need to make sure that they understand why the follow-up is important and what are the consequences on their child health if they miss the appointment. Also, we can link the follow-up to routine vaccination visits that the family will already go to that will lessen their visits to the hospital. Also, we can help them remember the appointment by calls or SMS or make the booking easier. Regarding our study, it's the largest to be done in Saudi about this topic. It's the first of its kind, and even though it was done in one hospital, it included families from all income levels, both civilian and military.
1 minute left.
And even some babies came from outside of Riyadh, so the data represented a wide group. Also, the 304 parents that missed the follow-up were individually contacted by our team. We didn't just call, we listened, answered their questions, addressed their fears. What started as a simple phone call as a data collection turned out into a small awareness campaign that helped those parents deliver the best care for their children at the right time. Yet, this is our only single study, a single center study only, so the data may not represent the whole country. Also, we relied on parental memories during the phone calls, so that can affect accuracy. At the end, our hearing screen national program is excellent, has high coverage, but with a very high loss to follow-up high loss to follow-up rate, which defeats the purpose of the screening program. And the main reason is parental awareness. And that responsibility relies on us as healthcare providers to deliver the right message to the family. At the end, I want to thank our nurses. Without them, this program wouldn't have been possible. I want to thank my co-authors and the Saudi Neonatology Society. Thank you all for listening.
Question? تفضل دكتور.
Yeah, actually, of the babies that were that we screened.
Can you show the slide again, معلش?
Okay.
Thank you.
It's already closed.
Haider, can you show the slide, please? Because it's not 2%, it's higher than that. I'll show you why.
Okay.
More.
I think I know which one.
Yes, here.
This one.
Okay,
Yeah.
so 8 infants confirmed with permanent hearing loss, تمام? Men is 62. 8 out of 62. That's like 13%.
That's part of the idea that alarmingly 8 infants were found to have to be confirmed with permanent hearing loss.
Yes, yes.
But we missed a lot of cases.
مظبوط، فأنت الدينومينيتور تبعك مش ال 300، الدينومينيتور 62، لأن 62 فقط هم رجعوا على العيادة for hearing assessment.
Yes.
منهم 8 طلع معهم، فبيطلع البيرمننت هيرنج لوس 13% من اللي فيلد أول تيست. This is يعني معلومة مهمة جدا إنه it's not 2%, it's 13%.
No, but we measure it from the all population, the 8,000.
No, لا
From
لحظة.
1.3 from
تمام.
1,000 screened babies.
8%, 2.1% out of what? 8%.
Out of the 8,000 screened babies.
لا، ما هو 8 على 8000 ما بيطلعش 2%. 8 على 304 بيطلع 2%. تمام. لكن it's not should not be 8 over 304. It's 8 over 62.
Okay. Yeah.
فبيطلع الانسنس لو الطفل failed الهيرنج assessment at birth، تمام؟
Yes.
احتمالية انه يطلع فعلا عنده permanent hearing loss 13%, not 2%. So that's a big number. يعني just to be aware of.
Thank you.
Thank you very much. That was our last presentation. The last one will not be able to present. They are not here. Back to you, Dr. Talal. Thank you.
Thank you very much for all of the presenters, and a lot of thanks for the moderators and also the judges. Thank you for taking notes and giving us the final score. So we'll release the name of the winners by the last day. We have the abstract competition, the poster competition, and also the winners. We'll announce them there. Winners for all of them will receive free registration for the next conference, along with the first place. They'll also get 3,000 riyals along with accommodation, 2,000 riyals for a second place, and the 1,000 riyals. And now we have concluded this scientific session. Thank you so much for all of the judges and the moderators again. And now we will move to our sponsor.